We have on behalf of Dr. Bhim Sapkota, the presentation will be given by Ravi Kant Mishra ji. Please, Ravi. And his presentation will be on efficient and responsive health system for quality and equitable health services and evaluation of our political revolution in Nepal. Ravi ji, please.
Okay, thank you. आदरणीय द्वय चेयर द्वय त्यसै गरी उपस्थित सम्पूर्ण व्यक्तित्वहरू म नेपालीमै प्रस्तुतिकरण गर्ने अनुमति पनि चाहन्छु। मैले यो इफिसिएन्ट एन्ड रेस्पोन्सिभ हेल्थ सिस्टम एन्ड इभोल्युसन ओभर पोलिटिकल रिभोल्युसन जुन चाहिँ मैले अन बिहाफ अफ डाक्टर भीम प्रसाद सापकोटा उहाँको इमर्जेन्सी कन्डिसनको कारणले गर्दा अहिले उहाँ चाहिँ उपस्थित हुन सक्नु भएन। उहाँको अन बिहाफमा म एज अ को अथरको रूपमा यहाँहरूसम्म चाहिँ प्रस्तुत गर्नेछु। फर्स्ट अफ अल मैले कन्टेक्स्ट अफ द स्टडीको सन्दर्भमा डेफिनेटली हेल्थको बिल्डिङ ब्लक्सलाई नै आधार मानिएर यसमा हामी छलफल गर्नेछौँ। जुन सिस्टम बिल्डिङ ब्लक्स अन्तर्गत हाम्रा 6वटा बिल्डिङ ब्लक्सको सन्दर्भमा एक्सेस, क्वालिटी, कभरेज, सेफ्टी र हामीले पेसेन्टको इन्गेजमेन्ट सँगसँगै हेर्ने हो भने हामीले यता 4वटा ओभरअल आउटकम हामीले देख्न सक्छौँ जसमा चाहिँ इम्प्रुभ हेल्थ हुनेछ, अर्को रेस्पोन्सिभनेस, सोसियल एन्ड फाइनेन्सियल रिस्क प्रोटेक्सन र इम्प्रुभ इफिसियन्सी छ। बेसिकली यो प्रेजेन्टेसनमा 2वटा आउटकम रेस्पोन्सिभनेस र इफिसियन्सीसँग रहेर म यहाँहरूसँग छलफल गर्नेछु। हामीले इफिसियन्ट एन्ड रेस्पोन्सिभ हेल्थ सिस्टम भन्ने बित्तिकै बेसिकली इफिसियन्ट भन्ने बित्तिकै एडिसनल रिसोर्सेस भर्सेस वाइज युज अफ लिमिटेड रिसोर्सेस, द्याट मिन्स हाम्रो इनपुट भर्सेस आउटपुटको सन्दर्भमा इन टर्म्स अफ क्वालिटी र म्याक्सिमम रिजल्टको सन्दर्भमा इफिसियन्ट लिन्छौँ भने रेस्पोन्सिभनेसको सन्दर्भमा एबिलिटी टु मिट द लेजिटिमेट एक्सपेक्टेसन अफ द हेल्थ केयर सर्भिस युजर्सको हिसाबमा हामीले लिने गर्छौँ। र यसै सन्दर्भमा मैले यो रेस्पोन्सिभको सन्दर्भमा एउटा न्युज यहाँहरू समक्ष मैले राख्न गइरहेको छु जसमा रिसेन्टली हाम्रो लिडरसिपबाट, स्वास्थ्यको लिडरसिपबाट जनअपेक्षा अनुसार सेवा दिन सकिएको छैन भनेर भन्नुभएको छ। द्याट मिन्स अलिकति रेस्पोन्सिभनेसमा मैले यहाँ जोड्न चाहेँ। र हामीले हाम्रो इभोल्युसन अफ हेल्थ सिस्टमको सन्दर्भमा विशेष गरेर हाम्रो अहिलेको हेल्थ सिस्टम चाहिँ विक्रम सम्वत 2000बाट सुरुवात भएको, अलिकति हामी चाहिँ त्यसमा चाहिँ अलिकति हामीले केही चिजहरू खोज्दा पाउने भनेको आफ्टर 2000 पछि हामीले पाउँछौँ र अहिले 80 वर्षको जुन लामो भनौँ अथवा छोटो यो अवधिमा सिरिज अफ पोलिटिकल चेन्जेसहरू भए जसमा स्ट्रक्चरल र फङ्सनल चेन्जेसहरू भए हेल्थ सिस्टममा पनि। र प्रत्येक चेन्जेसमा हामीले चाहेको के हुन्थ्यो भन्दा रेस्पोन्सिभ, एकाउन्टेबल एन्ड इफिसियन्ट हेल्थ सिस्टम नै हुन्थ्यो। र अहिले पछिल्लो सन्दर्भमा फेडरलाइजेसन भइसकेपछि केही हदसम्म हामीले च्यालेन्जहरू फेस गरेका छौँ इन टर्म्स अफ इन्फ्रास्ट्रक्चर, ह्युमन रिसोर्स फर हेल्थ, रिसोर्स इनएडक्वेसी, वेस्टेज, प्रोक्योरमेन्ट डिले, पुवर कोअर्डिनेसन, यी चिज बिहानदेखि हामी छलफल गरिरहेछौँ। विशेष त यसको अब्जेक्टिभ्स के छ त हाम्रो यो अनगोइङ नै छ, हामीले यसलाई कम्प्लिट गरिसकेको छैनौँ। त्यो प्रिलिमिनरी फाइन्डिङ नै हो। यो हामीले खास चाहिँ टु इन्भेस्टिगेट द इभोल्युसन अफ द रेस्पोन्सिभ एन्ड इफिसियन्ट हेल्थ सिस्टम ओभर द पास्ट फ्यु डेकेड्स, द्याट मिन्स 80 इयर्सको पिरियडमा के भइरहेछ र टु आइडेन्टिफाई द करेन्ट इस्यु एन्ड च्यालेन्जेस इन द नेप्लिज हेल्थ सिस्टम कन्सर्निङ रेस्पोन्सिभनेस र इफिसियन्सीलाई मात्रै पिक गरेर हेर्ने हो भने। र हाम्रो मेथड भनेको डेफिनेटली यो एक्सप्लोरेटरी अथवा हामीले डकुमेन्ट रिभ्यू गर्ने हामीले गरेका छौँ, जमर्को गरेका छौँ। र हामीले चाहिँ अलिकति पोलिसी मेकरहरूसँगको चाहिँ छलफललाई पनि सँगसँगै जोडेका छौँ। यो चिजलाई रहेर हामीले चाहिँ यो स्टडी गर्ने जमर्को गरेका हौँ। प्रिलिमिनरी फाइन्डिङ के छ त भन्ने सन्दर्भमा चाहिँ मैले यो कुन समयमा के गरियो भन्नुभन्दा पनि विक्रम सम्वत 2007 देखि 36 सम्मको पिरियड भनेको पोलिटिकल रिभोल्युसनमा हामी पञ्चायत पिरियडमा विशेष र पोस्ट डेमोक्रेसी पहिलो जुन हामीले चाहिँ प्रजातन्त्र पछिको अवस्थामा हेर्ने हो भने देयर आर सो मेनी चेन्जेस। त्यो चेन्जेसलाई हामीले हेर्ने हो भने इन टर्म्स अफ इफिसियन्सी र रेस्पोन्सिभनेसमा हेर्ने हो भने अलिकति बढी इफिसियन्सी चाहिँ राम्रो र रेस्पोन्सिभनेस चाहिँ अलिकति कम हो कि भन्ने फिल गर्छौँ भने त्यसै गरी जनमत सङ्ग्रह 2036 साल पछिको जुन जनमत सङ्ग्रह छ जसमा 2038 देखि 2046 सालसम्मको पिरियडको सन्दर्भमा जति पनि हामीले चाहिँ स्वास्थ्य क्षेत्रको एउटा मेजर माइलस्टोनको रूपमा पिएचसी जुन अल्माटा कन्फरेन्स छ त्यसलाई नै एडप्ट गरेर चाहिँ हाम्रो चाहिँ पछि जति पनि एक्टिभिटीहरू पिएचसी बेस्डमा भएको छन् त्यसमा हाम्रो इफिसियन्सी अलिक घट्दो र रेस्पोन्सिभ अलिकति बढी हो कि भन्ने फिल चाहिँ यो स्टडीको पिरियडमा हामीले पाथ्यौँ भने आफ्टर द पोस्ट डेमोक्रेसी मुभमेन्ट 2047 सालपछि हाम्रो चाहिँ स्वास्थ्य क्षेत्रमा अलिकति सिस्टम बेस भएर पहिलो नेसनल हेल्थ पोलिसी हाम्रो चाहिँ जारी भएको थियो। त्यसपछि स्वास्थ्य संस्थाहरू कम्युनिटी लेभलदेखि हाम्रो हायर लेभलसम्म टर्सियरी लेभलसम्मका स्वास्थ्य संस्थाहरू इस्टाब्लिसमेन्ट भएको सन्दर्भमा हामी इन्फ्रास्ट्रक्चरमा राम्रो गऱ्यौँ, पोलिसीमा राम्रो गऱ्यौँ, तर इफिसियन्सी अझै घट्दो र रेस्पोन्सिभ अलि बढेको हो कि भन्ने चाहिँ हामीले यो पाएका थियौँ। त्यसै गरी 2062-63 को दोस्रो जनआन्दोलन पछिको पिरियडमा हेर्ने हो भने हाम्रो चाहिँ सेकेन्ड लङ टर्ममा एसेन्सियल हेल्थ केयर सर्भिस प्याकेजमा 20 वटा सर्भिसहरू हामीले चाहिँ त्यसमा पहिलादेखि गर्दै आएका थियौँ भने यो इन्टेरिम कन्स्टिट्युसनले चाहिँ अलिकति हेल्थलाई राइट बेस एप्रोचमा लिएर गएको छ। त्यो राइट बेसले गर्दा रेस्पोन्सिभ अलिकति बढी र इफिसियन्सी पहिलाको तुलनामा अझै कम हो कि भन्ने फिल पनि छ। र 2072 हामीले चाहिँ फेडरलाइजेसनमा गइसकेपछि नेपालको सन्दर्भमा नयाँ कन्स्टिट्युसनको साथसाथै हामीले चाहिँ 31 वटा मौलिक हकमा स्वास्थ्यलाई पनि एउटा मौलिक हकको रूपमा राखेका छौँ भने रहेको छ भने जस अन्तर्गत स्वास्थ्यलाई फन्डामेन्टल ह्युमन राइट्स को रूपमा लिएको छ र त्यसको बेस टाइममा हामीले पब्लिक हेल्थ सर्भिस एक्टदेखि लिएर गएर सेफ मदरहुडको एक्टदेखि लिएर गएर रेगुलेसन नेसनल हेल्थ पोलिसी हामीले 2076 जारी गऱ्यौँ। हामीले भर्खरै मात्र नेसनल हेल्थ फाइनेन्सिङ स्ट्राटेजी र हामीले चाहिँ नेपाल हेल्थ सेक्टर स्ट्राटेजिक प्लान जस्ता एकदम गाइडिङ डकुमेन्टहरू तयार गरेका छौँ। यो अवस्थामा सरसर्ती हेर्ने हो ओभर द यो पिरियडमा हेर्ने हो भने इफिसियन्सी टु सम एक्सटेन्ट अलिकति कम हुँदै गएको र रेस्पोन्सिभनेस चाहिँ अलिकति बढी भएको चाहिँ यो हाम्रो टिमले चाहिँ यो आइडेन्टिफाई गरेको चिज र इफिसियन्टको सन्दर्भमा हामी कहाँनेरि के छौँ त भन्ने सन्दर्भमा योबाट पनि हामी क्लियरली हुन सक्छौँ। यो स्टाग्नेन्ट जस्तो छ, यो बढिरहेको छैन भने रेस्पोन्सिभनेसको कुरा गर्ने हो भने चाहिँ कभरेज अफ द एसेन्सियल हेल्थ केयर सर्भिस जुन इन्डेक्स छ त्यो इन्डेक्स चाहिँ स्लाइटली बढ्दै गएको हामीले चाहिँ भेटाउँछौँ। द्याट मिन्स इफिसियन्टमा हामीले केही प्रगतिहरू जति रिमार्केबल हुनुपर्ने त्यो देखिँदैन भने हामीले रेस्पोन्सिभमा स्लाइटली यो बढ्दो क्रममा देखिएको चाहिँ हामीले पाउन सक्छौँ। र यति भनिरहँदाखेरिमा हाम्रो हेल्थ सिस्टममा केही इस्यु र च्यालेन्जहरूलाई हामीले आइडेन्टिफाई गर्ने प्रयास गरेका छौँ। इस्यु र च्यालेन्जेसको कुरा गर्ने हो भने हामीसँग यो बिहानदेखि म बिहान पनि अलिकति इफिसियन्सीको कुरा गरिरहेको थिएँ, त्यहीसँग यो जोडिएर पनि आइरहेछ। मल्टिपल सोसल सेक्युरिटी विन्डोजहरू हामीसँग छ। बिहानको प्रेजेन्टेसनमा डाक्टर गुण र मैले पनि प्रेजेन्ट गर्ने बेलामा यो चिज मैले देखाएको थिएँ। त्यतिखेर पनि हामीसँग सेभरल भर्टिकल्स के छन् त भन्दा सोसल सेक्युरिटी विन्डोजहरू छन् जसले चाहिँ इफिसियन्ट युज अफ लिमिटेड रिसोर्सलाई क्वेसन गरेको छ भने ओभरल्याप इन द फ्री बेसिक हेल्थ केयर सर्भिस र बेनिफिट प्याकेज अफ द हेल्थ इन्सुरेन्समा पनि अलिकति ओभरल्याप छ जसले हामीलाई डुप्लिकेसन गराइरहेछ। वर्कलोड स्ट्रेस बर्नआउट सिन्ड्रोम हेल्थ वर्करहरूमा बढ्दो छ। पछि गएर अहिले हामीले हेर्ने हो भने राइट बेस एप्रोचमा धेरै छ र त्यसमा भायोलेसनका कुराहरू छन्, म्यानेजमेन्ट कम्पिटेन्सीका कुराहरू छन् हेल्थ सर्भिस म्यानेजर स्पेसली इन द लोकल लेभलमा। त्यसै गरी सस्टेनेबल फाइनेन्सिङको कुराहरूमा चाहिँ गभर्मेन्ट फाइनेन्सिङ, हेल्थ इन्सुरेन्स, हाई ट्याक्स अन हेल्थ जुन हार्मिङ प्रोडक्ट्सहरूको कुराहरू पनि सँगसँगै जोडिएर आउँछन्। र अलिकति हामीले पोलिसीमा चाहिँ यसलाई विशेष गरेर हामीले गभर्मेन्टले बढी ओन गर्ने, गभर्मेन्टको फन्डिङ बढाउँदै जाने र प्राइभेट सेक्टरलाई रेगुलेट गर्ने खालको हामीले चाहिँ पोलिसीलाई एडप्ट गरेका छौँ। तर पनि हामीसँग च्यालेन्जेस चाहिँ कमर्सियलाइजेसन अफ द हेल्थ केयर सर्भिसेसहरू छन्। त्यसै गरी रिजिड ब्युरोक्रेटिक प्रोसेस फर द हेल्थ सर्भिस युटिलाइजेसनमा क्राउडेड ओभरसाइट अथवा इमर्जिङ इन रिसेन्ट डेज चाहिँ हामीले चाहिँ यो पाउन सक्छौँ। दिज आर द यी बिहानदेखि हामीले छलफल गरिरहने सन्दर्भमा यो चिजहरू पनि छ। यसमा हामीले अझै फर्दर गहिरिने प्रयास गर्नेछौँ। वाट मेक्स द हेल्थ सिस्टम इफिसियन्ट भन्दा अलि बढी फोकस्ड हेल्थ वर्कफोर्स फाइनेन्सिङको पार्ट मेथड र प्रोसिडियरमा गर्नुपर्ने छ भने रेस्पोन्सिभको लागि हामीले चाहिँ मिटिङ द एक्सपेक्टेसन अफ द क्लाइन्ट्स भर्सेस एचिभिङ द एक्सपेक्टेसन द्याट मिन्स टार्गेट अफ द प्रोग्रामलाई मिट गर्नुपर्ने छ। एज एक्सपेक्टेसन अफ द टार्गेट ग्रुपलाई हामीले मध्यनजर गरेर जसमा इक्विटीका कुराहरू पनि सँगसँगै जोडिएर आउँछन्। र कन्क्लुजनमा म पुग्न चाहन्छु, हामीले यो ओभर द 80 इयर्स हेर्ने हो भने हेल्थ सिस्टम हेज पास द प्रोग्रेसिभ डेभलपमेन्ट, हामीले धेरै प्रगतिहरू गरेका छौँ। यद्यपि र यो प्रगति पोलिटिकल रिभोल्युसनको सँगसँगै हेल्थ सिस्टममा पनि हामीले मोर रेस्पोन्सिभ बट लेस इफिसियन्ट हेल्थ सर्भिस डेलिभरी मेकानिजम हो कि अब हामीले चाहिँ यो दुईटाको बिचमा ट्रेड अफ खोज्नको लागि म यो रिसर्चरहरूलाई चाहिँ यो प्रश्न पनि छोड्न चाहन्छु र ड्यू टु द इमर्जिङ च्यालेन्जेस कज बाई चेन्ज सोसियो इकोनोमिक डेमोग्राफिक एन्ड इपिडेमोलोजिकल कन्टेक्स्टको सन्दर्भमा एड टु इम्प्रुभ रेस्पोन्सिभनेस एन्ड इफिसियन्सी इन हेल्थ सर्भिस डेलिभरी हामीले अब यी चिजहरूलाई मध्यनजर गरेर हाम्रो अहिले भइरहेको हेल्थ सिस्टमलाई कसरी इफिसियन्ट र कसरी रेस्पोन्सिभ बनाउन सकिन्छ भन्ने चिज नै हो. हियर आर द रिफरेन्सेस द्याट वी युज्ड. थ्याङ्क यू.
Move for the next presentation. At the end, we may have a few questions and discussions. Next presentation, Dr. Sushil Baral. So Dr. Sushil is here on behalf of some, okay. Yeah, on behalf of Dr. Sushil, his colleagues from the Policy and System Health Institute, he will give the presentation.
Namaste. I'll be presenting on behalf of our team. It includes Dr. Sushil Baral, Achyut Raj Pandey, myself, and Harvey. So I'll be presenting on behalf of the team. So my presentation is mainly on health policy system research institutions. We had a project, it was FAB HIP series. The project mainly entailed developing a framework. In this presentation, I'm mainly going to talk about the framework, what was the lessons learned, and what are the future directions for health policy system research. So my presentation is going to include the landscape, the context for health policy system research in Nepal. We're going to talk about the process of the creation of the capacity assessment framework. And we're going to talk about the framework itself, what the framework holds, what's its values and everything. And we're also going to talk about the lessons learned and future directions with health policy system research, or HPSR in short. So as you can see, the figure presents the landscape of health policy system research in Nepal. The figure shows who the major actors in health policy system research are. As we can see in the figure, so in one side of the spectrum are health policy system research institutions, and those includes individual research institutions and researchers. That includes NGOs, INGOs, and other private research institutions. And it also includes academic institutions. And other than that, it includes individual researchers and scholars. And on the other side of the spectrum, we have policy-making bodies. It includes bodies from the federal, provincial, and local level. And on the middle, we have funding agencies. So this figure, it mainly shows how the different actors interact and how do they work together? How do they support each other? So I'm not gonna really go much into the detail, but as you can see, this is the general operating framework for health policy system research in context of Nepal. Speaking of the context and issues that we're having with health HPSR is that now the importance of HPSR is slowly starting, people have started to realize, but it has to be noted that it's pretty patchy and the progress is pretty slow. And there's also limited culture of impact assessment of health system strengthening interventions, and that hinders the evaluation of health system effectiveness. And we can also see there's a gap, there's okay. We can also see there is gap in terms of evidence gap in terms of making high impact and low cost interventions. And it's evident that there is limited research capacity, and that acts as barriers towards effectively tackling health challenges and emerging health issues. And all of this points to a need for a capacity assessment of different health policy system research institutions, and it pointed towards the need of having a robust framework to measure to assess the capacity and to measure the competence of different institutions. So the main objective was to identify what attributes what are the attributes for a robust health policy system research institution. So what is needed for an institution to be robust? So that was our first motive. And the second one was to co-create a capacity assessment framework to assess the research capacity for health policy system research institutions. And the important thing here is co-creation. So what we did throughout the project, we were involved in a series of different steps, all involving co-creation. So first, what we did was we conducted a preliminary literature review just to identify what qualities should institutions working on health policy system research possess. And so we did the literature review. We came up with designated domains for capacity assessment. Then we further refined the domains through 20 key informant interviews that involved different people's representatives from SIPSERIs, academic institutions, policy level, representatives from the policy level. So we had an interview of 20 different experts, and that further guided us to the next step. So that was the joint workshop. Then we had a series of workshops, each shaping the next workshop. And at the end of the workshop, the aim of the workshop was to, as mentioned before, was to co-create a capacity assessment framework. And so every step, every workshop shaped our framework in a different way. I'm just going to run very briefly through what are the current issues that HIPSERIs are having to deal with. At the system level, there are evidence gaps, and they are not clearly identified. Institutionalization of learnings is yet to be fully shaped, and there is very limited collaboration, particularly within academic institutions and policy. And there's very weak linkages between academic institutions and the policy level. And also there's very limited resources for HPSR. And there is a lack of technical capacity in many spectrums. And at the organizational level, the understanding of HIPSERIs is different among different stakeholders. There's limited institutional home for learning, and there's lack of incentive for continuous engagement. And there's also weak coordination between different agencies, leading to duplication of work. And I mentioned this before, there's very limited linkage and network and connection to the wider system. And at the individual level, again, we are talking about capacity. Professionals they have different understanding. There's limited opportunities for HPSR grants. And there's very weak evaluation of HPSR, and there's lack of interest due to lack of continuation. So this is the framework. Our framework is, it mainly has 4 domains. Some are more heavily loaded, like for instance, technical competency is more heavily loaded. It has more subdomains. But these are the 4 core areas in which we measure the capacity of an organization. So one is their ability to manage. The other one is their ability to inform policy. The other is their technical competency. And the other one is their ability to collaborate and co-create, and also their ability to be involved in a network. So in terms of measuring capacity, so we use the 2-prong approach. So what we are looking at is, for the current practices, we will be looking at what HIPSERIs are doing and what is supposed to be done. So and that's one way we measure capacity, and also we're gonna check for discrepancies between what is available and what is needed. And capacity we're gonna measure in terms of basic, medium, and advanced. So I'm gonna skip a couple of slides considering the time. So so the tool, What's the future use of the tool? So number one, we believe it can be used by HIP series for periodic self-assessments. They can check in specific periods of time to see whether they have progressed or the capacity is the same or they have gone downhill or whatever the case is. So that can be used as a tool for periodic assessment. It can also be used as a tool for periodic assessment of capacity by NHRC. It can be used as a preliminary step for planning capacity development initiatives, and it can be used as a tool for categorization of research institutions based on the capacity. There are some limitations with the tool. The first one is computing a composite score and comparing organizations based on the score could be very challenging because of the diverse nature of work. And also, not all questions in the tool are applicable to all organizations, and hence that affects the total points on which the capacity is scored, and it can be different, it can be misleading sometimes. And also, the nature of organizations evolve over time, and some questions that are not relevant at this point of time might be important later. So, future actions. So now that we have the tool, what we can do is we can institutionalize the tool. We can, so that means we can pilot the tool in larger institutions and facilitating the use on a regular basis. We can develop a video tutorial for the tool, basically guiding the users to aid their application of the tool. We can also make multiple versions of the tool for different, considering the nature of the organization. It can be used for knowledge dissemination, wider dissemination of findings. We can have paper publications, conference presentations, and several policy dialogues. And we can establish a network of HIP series, and we can also aim for capacity development at all three levels, individual, organizational, and system level. So I'm going to wrap up really quick. So the key takeaway messages here is HIP series, HPSR itself it's very tough to define, and it's defined more by the issue it addresses. And it's very tough to have a clear differentiation from other types of research. There's a diversity in the interest of actors by the area of work, by the nature of funding, and the functions. So by area of work, some are working in policy analysis, some are involved with program evaluation in terms of funding, some are funded by the government, some have external sources of funding. In terms of functions, some are academic institutions, some are research organizations, some are policy-making bodies, and also program implementing agencies. The other messages are, so HPSR is a multidisciplinary field, and it combines methods from multiple disciplines, and it's very difficult to have exhaustive list of methodological skills required. And there are vast contextual differences in terms of organization and structure from one setting to other, and it needs highly contextualized and tailored research methodologies. And also addressing all these complexities in a single tool can be very challenging, it's very complex, and workshop participants suggested that we have multiple versions of the tool. So one lessons, something we need to learn is that it's very important to differentiate between individual and institutional capacity. They can be confusing at times. And it's also important to balance trade-off between comprehensiveness and length of questions. And it's also, people have different understanding on what constitutes HPSR's research capacity, and organizations tend to look for their own agenda in the capacity assessment tool. So yeah, that's it. Thank you.
Thank you, Mr. Bipul, for your presentation. Now we have a next presentation, Bikesh Bajracharya. He will be presenting on choice of sustainable health financing reform options for attaining universal health coverage in Nepal, stakeholders' perspective. Bikesh is a PhD scholar and researcher at the School of Human and Health Sciences, University of Huddersfield, UK, and he's researching on the health financing challenges and opportunity and universal health coverage as well. He have many years of experiences working with the different diverse organizations, UN agencies and other organizations. With this, I would like to request to Vikesh we give the presentation, Choice of Sustainable Health Financing Reform Options for Attaining Universal Health Coverage in Nepal. Yeah, Mr. Vikesh, please.
Thank you, Chairs. So as the Chair mentioned, today I'll be discussing about sustainable health financing reform option for attaining universal coverage in Nepal. And this is a stakeholder prospective study. So myself, Vikesh Bajajare, and my supervisors, Professor Pradam Smikara and Professor Anne Louise from School of Human and Health Sciences from University of Huddersfield, and Professor Simon from University of Sheffield. So this is the outcome of the outline of the presentation based upon the research. So with permission, I will be talking in both in English and Nepali for the convenience of everyone. So हामी बिहानदेखि नै हामीले सुन्दै आइरहेका छौँ कि नेपाल सरकारले युनिभर्सल कभरेजसम्म पुग्ने भनेर 2030 सम्मको कमिटमेन्ट गरिसकेका छन् हैन र विभिन्न माध्यमबाट कसरी पुग्ने भन्ने कुराहरु विभिन्न अप्सन्सहरु हामीले बिहान कुरा गर्यौं तर अर्को एउटा इम्पोर्टेन्ट अप्सन्स भनेको पनि हेल्थ फाइनान्सिङ एउटा क्रिटिकल कम्पोनेन्ट पनि हामीले हेर्नुपर्छ हैन जसले चाहिँ यो अब युएससी प्रोग्रेस गर्नको लागि फ्यासिलिटेट गर्छन् भन्ने कुरा भयो र नेपालको सन्दर्भमा अघि बिहान पनि कुरा गरेका छन् साथीहरूले कि विभिन्न सोशल प्रोटेक्सन स्किम्स अथवा हेल्थ फाइनान्सिङ मोडल्सहरू नेपालमा छन् जो अहिले नेपालमा हेर्यो भने मिक्स मोडल छन् जहाँ चाहिँ हामीले ट्याक्स फन्डेड फ्री हेल्थ केयर भनेर एउटा धारलाई लिन सकिन्छ भने अर्को धारमा हामी कन्ट्रिब्युसन बेस हेल्थ इन्सुरेन्स छ भनेर दुई धारको सन्दर्भमा हामी छलफल गर्न सक्छौँ त्यसैगरी मेरो यो स्टडी विशेष गरी यो कुजिन फ्रेमवर्क अफ हेल्थ फाइनान्सिङ फर युनिभर्सल कभरेज एन्ड हेल्थ सिस्टम पर्फर्मेन्समा आधारित छन् हैन र कुजिनले के भनेका छन् भने हेल्थ सिस्टममा ओभरअल हेर्ने हो भने हेल्थ फाइनान्सिङ पनि एउटा इम्पोर्टेन्ट कम्पोनेन्ट हो र हेल्थ फाइनान्सिङ अन्तर्गत रेभेन्यू कलेक्सनका कुराहरू हुन्छन् त्यसरी पुलिङ हैन रिस्क पुलिङको कुराहरू छन् र पर्चेजिङ र बेनिफिट प्याकेज कसरी डिजाइन गरेका छन् त हैन यदि हामीले कुनै पनि हेल्थ फाइनान्सिङ मोडल हेर्ने हो भने फर इक्जाम्पल हेल्थ इन्सुरेन्स हेरे पनि त्यसमा रेभेन्यू रेज गर्छन् इदर प्रिमियम उठाएर हुन्छ कि नेपाल सरकारको ट्याक्स मनीबाट हुन्छ त्यसमा पुल गरेका हुन्छन् हामीले सबै जनताहरूलाई एउटा त्यही हेल्थ इन्सुरेन्समा इनरोल गरौँ भनेका छौँ जबकि अहिलेसम्म हेर्ने भने 26% मात्र इनरोल भएका छन् पर्चेजिङ मेकानिजमको लागि हेल्थ इन्सुरेन्स बोर्ड इस्टाब्लिस गरेका छन् जुन चाहिँ एउटा अटोनोमस पर्चेजिङ एजेन्सीको रूपमा काम गर्छन् र बेनिफिट प्याकेजको पनि उहाँहरूले लिस्ट गरेका छन् त्यसरी ट्याक्स फन्ड फ्री हेल्थ केयरको रूपमा अब आमा प्रोग्राम विपन्न अथवा कुनै पनि भर्टिकल प्रोग्राम लिने हो भने हैन स्वास्थ्य मन्त्रालय अन्तर्गत यी नै फङ्सन्स आउँछन् रेभेन्यू रेजिन पुलिङ पर्चेजिङ र बेनिफिट प्याकेजका कुरामा भनेपछि हामीले चाहिँ स्किम्स भन्दा पनि इट्स मोर अबाउट हाउ रेभेन्यू रेजिन आर रेज हैन पुलिङ कसरी भइरहेका छन् पर्चेजिङ मेकानिजम कुन अपनाएका छन् र बेनिफिट प्याकेज कस्तो अपनाएका छन् त यो तालमेल मिलाउन सक्यो भने यसले चाहिँ युनिभर्सल कभरेज पुग्नको लागि युनिभर्सल कभरेजको इन्टरमिडिएट अब्जेक्टिभ र युएससीको गोल्स चाहिँ पुग्न यसले टेवा पुर्याउने छन् भन्ने कुरा बताएका छन् र यही फ्रेमवर्कमा टेकेर मैले यो स्टडी गरेको छु र यसलाई अगाडि हेर्दा मेनली यो स्टडीको दुईवटा अब्जेक्टिभ छन् एउटा भनेको स्टेकहोल्डर पर्सपेक्टिभ बुझ्न हो जहाँ चाहिँ उहाँहरूको चोइस के हो त अब हामीका एकदमै अन्यल छ हामी युनिभर्सल कभरेज पुग्छौँ कि पुग्दैनौँ कुन चाहिँ मोडलबाट जाने हो विभिन्न स्किम्सहरू छन् भन्ने कुरामा अब उहाँहरूको पर्सपेक्टिभ के हो त यसमा कुन मोडल पुग्नुपर्छ त हैन कुन मोडलको सिलेक्सन गर्नुहुन्छ नि त इन टर्म्स अफ रेभेन्यू रेजिन पुलिङमा कसरी जान सकिन्छन् पर्चेजिङ र बेनिफिट प्याकेजमा कसरी डिजाइन गर्नुपर्छन् भन्ने कुराहरू हामीले छलफल गरेका छौँ र त्यसरी अर्को अप्सन्स भनेको ती मोडल्सहरू नेपालको सन्दर्भमा त्यो कतिको फिजिबल छ त इम्प्लिमेन्ट गर्नको लागि त्यसका च्यालेन्जेसहरू के हुन् अथवा स्ट्राटेजी के अपनाउन सकिन्छ त तिनीहरूलाई चाहिँ हामीले इम्प्लिमेन्ट गर्नको लागि ताकि हामी 2030 सम्म युएससी पुग्नको लागि हामीले प्रोग्रेस गर्छौँ भनेर यो स्टडीको मेन दुईवटा अब्जेक्टिभ भयो र एउटा क्वालिटेटिभ स्टडी हो जहाँ चाहिँ मैले 28 वटा इनडेप्थ इन्टरभ्यू लिएका छौँ हैन 2022 मा र स्टडी पार्टिसिपेन्टको रूपमा हेर्ने हो भने बेस्ड अपन द क्वान्टिटी हैन डेभलपमेन्ट पार्टनर गभर्नमेन्ट एजेन्सिजहरू त्यसैगरी हेल्थ इन्सुरेन्स बोर्ड र सोसल सेक्युरिटी फन्ड फेडरल हस्पिटल्स एकाडेमिया र त्यसै गरी सोसल सेक्युरिटी फन्ड र ट्याक्स अफिस डिपार्टमेन्ट अफ हेल्थ सर्भिसलाई मैले इन्टरभ्यू ल्याएको छु जुन चाहिँ की स्टेक होल्डर हुन् जहाँ चाहिँ हेल्थ फाइनेन्सिङ स्ट्राटेजी बनाउने र त्यसै गरी यी विषयवस्तुमा उहाँहरू डे टु डे डाइरेक्ट काम गर्नुहुन्छन् र कन्टेन्ट एनालाइसिस बेस अपन द थिम्स होइन इन्टरभ्यूबाट आएकोबाट मैले एनालाइसिस गरेको छु यो र रिजल्ट्समा हेर्ने हो भने विशेष गरी रेभिन्यू रेजिममा विभिन्न अप्सन्सहरू छन् होइन यी कति अप्सन्सहरू चाहिँ यो एसिया पेसिफिक कन्ट्रीका रिलिभेन्ट अप्सन्स मध्येबाट ल्याएको छु र त्यसरी कति स्टेकहरू आफैले पनि ल्याएका छन् र ती अप्सन्स मध्येमा होइन यो ट्राफिक लाइट सिग्नलबाट उहाँले भनेको होइन जुन इन्टरभ्यू छन् त्यसका आधारमा हेर्ने हो भने द बेस्ट अप्सन भनेको उहाँले हाइलाइट गरेको भनेको बजेट चाहिँ 10% नै ट्याक्स मनीबाट एलोकेट गर्ने नै एउटा बेस्ट मेथड हो अहिलेको लागि भन्ने बताएका छन् त्यसै गरी अरू अप्सन्सहरूमा जस्तै सिन ट्याक्स लिभिङ ट्याक्सहरू पनि लगाउन सकिन्छन् तर त्यसबाट एकदमै स्मल क्वान्टिटी मात्रै ट्याक्स उठ्छन् सो द्याट डजन्ट मेक मच सेन्स त्यो भन्दा पनि हामीले 10%लाई नै हामीले टार्गेट गर्नुपर्छ भने उहाँहरूको चाहिँ बेस्ट अप्सन हो अबको बाटोको लागि भन्ने भनेका छन् र त्यसै गरी यो म्यान्डेटरी एयरमार्क हुनुपर्छ हेल्थ इन्सुरेन्सको लागि र त्यसको लागि पनि विशेष गरी फर्मल सेक्टरलाई चाहिँ पेरोलबाट ट्याक्सबाट चाहिँ हामीले चाहिँ स्यालेरीबाट पैसा उठाउनुपर्छ भन्ने कुरालाई चाहिँ यो दुईवटा अप्सन्सलाई चाहिँ उहाँले हाइलाइट गर्नुभएको छन् र अर्को एक्सटर्नल फन्डिङलाई चाहिँ उहाँले एकदमै डिस्करेज गर्नुभएको छन् किनकि त्यो एउटा सस्टेनेबल फाइनेन्सिङ रेभिन्यू रेज मोडल होइनन् भन्ने कुरा बताएका छन् र त्यसै गरी जुन चाहिँ नन पोरहरू छन् जसलाई इन्सुरेन्समा आबद्ध गर्न सकिरहेका छन् उहाँहरूलाई पनि चाहिँ नन कन्ट्रिब्युटरी मेथडबाट चाहिँ जानुहुन्न कन्ट्रिब्युसन उठाएर नै जानुपर्छन् भन्ने चाहिँ त्यो मोडल्सलाई चाहिँ उहाँले प्रपोज गर्नुभएको छन् पुलिङको रूपमा हेर्ने पुलिङ मेकानिजममा हेर्ने हो भने विशेष गरी उहाँहरूको जोड रहेको भनेको नै जति पनि हेल्थ इन्सुरेन्स स्किम्सहरू छन् र त्यसै गरी फ्री हेल्थ केयर जति नाम गरेका फ्री हेल्थ केयर भनेर आमादेखि लिएर विभिन्न प्रोग्राम्सहरू छन् ती सबैलाई अब वान डोर एप्रोचबाट मर्ज गरेर नै जानुपर्छन् यो नै बेस्ट मेथोलोजी भनेर अप्सन्स उहाँहरूले चाहिँ हाइलाइट गर्नुभएको छन् र त्यसै गरी कम्पलसरी इनरोलमेन्ट अफ पपुलेसन भनेर चाहिँ इन हेल्थ इन्सुरेन्स चाहिँ हाइलाइट गरेका छन् जुन हाम्रो एक्ट रेगुलेसनमा पनि आइसकेका छन् तर हामी त्यहाँ पुग्न सकिरहेको अवस्था छैन पर्चेजिङ मेकानिजममा हेर्ने हो भने उहाँहरूको जो विशेष गरी पर्चेजर र प्रोभाइडर स्प्लिट हुनुपर्छ भनेर छन् हामीले हेल्थ इन्सुरेन्समा हेर्ने भने कहीँ कतै अब यो पर्चेजर एजेन्सीको रूपमा आइसकेका छन् त्यही पनि मन्त्रालयका अरू फ्री हेल्थ केयर स्किम्समा मन्त्रालय आफै पर्चेजर प्रोभाइडर र रेगुलेटरको रूपमा फङ्सन गरिरहेका छन् भन्छ त्यो पर्चेजर चाहिँ सेपरेट हुनुपर्छ ताकि त्यो रेगुलेट गर्न मोनिटरिङ गर्न इजी हुन्छन् र यसले चाहिँ इफेक्टिभ सर्भिस डेलिभर गर्न सकिन्छन् भन्ने कुरा आएका छन् र विशेष गरी अर्को भनेको पे फर पर्फर्मेन्स हामी अझ पनि आउटपुट बेस्ड पेमेन्टमा जानुपर्छन् भन्ने कुरा चाहिँ ल्याएका छन् हामीले अहिले पनि यो स्यालेरी लाइन आइटम भन्दा पनि उहाँले चाहिँ पर्फर्मेन्सको आधारमा क्वालिटी सर्भिस कति डेलिभर गरे कति सक्सेस सर्जरीहरू भए त्यसको आधारमा चाहिँ अबको पेमेन्ट बाटो तय गए मात्रै युनिभर्सल कभरेज र क्वालिटी सर्भिस डेलिभर गर्न सकिने भन्ने कुरा ल्याएका छन् र त्यसरी अरू अप्सन्स जुन चाहिँ उहाँहरूले चाहिँ जस्तै डिआरजीमा जाने स्ट्राटेजिक पर्चेजिङ र सिङ्गल पर्चेजरलाई एकदमै फोकस गरेका छन् मल्टिपल पर्चेजर भन्दा पनि सिङ्गल पर्चेजर ताकि त्यो हेल्थ इन्सुरेन्स होस् अथवा कुनै अर्को एजेन्सी त्यो उसमा जानुपर्छ भन्ने कुरा बताएका छन् बेनिफिट प्याकेजको हकमा कुरा गर्ने भने देयर इज एकदमै रिजर्भेसन भनेको कम्प्रिहेन्सिभ बेनिफिट प्याकेज विदाउट सिलिङ बिनाको बेनिफिट प्याकेज अब जान सक्ने अवस्था चाहिँ छैन नेपालमा किनभने हाम्रो बजेट कन्स्टेन्ट एकदमै लो छ र विदाउट सिलिङ हामी जान सक्दैनौँ त्यही भएर पनि अहिले इन्सुरेन्सको र अरू जति पनि सोसल प्रोटेक्सन स्किम छन् होइन अब इन्सुरेन्सको हकमा 1 लाखसम्म दिएका छन् भने अब त्यसलाई कतिसम्म बनाउन सकिन्छ तर विथ लिमिटेसन चाहिँ हुनुपर्छन् भन्ने कुरा बताएका छन् त्यसै गरी अर्को भनेको एकदमै हामीले पोरलाई बेस भएर चाहिँ हामीले सर्भिस दिइरहेका छौँ भन्छ त्यसरी चाहिँ बेनिफिट प्याकेजहरू पनि पोर स्पेसिफाई चाहिँ गर्नु राम्रो होइन किनभने त्यो इक्विटी बेस हुँदैनन् पोर भन्दा पनि जो चाहिँ सिक्छन् होइन जो बिरामी छन् बिरामीहरूले चाहिँ सेवा लिनुपर्छन् भन्ने कुरा आएका छन् र यसमा मेन चोइस अफ दि अप्सन्स भनेको एग्रिडेसन अफ सर्भिस प्रोभाइडर र कोपेमेन्टमा जानुपर्छ भन्ने कुरा चाहिँ ल्याएका छन् सो समअप गर्दा यी अप्सन्सहरू चाहिँ आएका छन् र यसमा विशेष गरी अबको फिजिबिलिटी र च्यालेन्जेस के हुन् त होइन अहिलेसम्म हेर्ने हो भने इम्प्लिमेन्टेसन हाम्रो कुनै पनि भएको छैन कोपेमेन्ट ल्याए तापनि देयर सम रिजर्भेसन इन टर्म्स अफ आर्टिकल पब्लिस यसले युनिभर्सल कभरेज पुग्छ पुग्दैन त्यो हामी डिबेट गर्न सक्छौँ होइन र अब फिजिबिलिटी र च्यालेन्जमा हेर्ने हो भने विशेष गरी च्यालेन्जेसमा अब हामीले 10% बजेट एलोकेसन हेल्थ सेक्टरलाई गर्न सकिन्छ कि सक्दैन त भन्ने कुरामा हेर्ने हो भने जस्तै हाम्रो फिजिकल सेप एकदम न्यारो छ होइन एब्जर्भमेन्ट क्यापेसिटी मन्त्रालयको एकदमै कम छन् त्यसै गरी एयरमार्क होइन ट्याक्स फर हेल्थ गर्न सकिरहेको अवस्था छैन यी च्यालेन्जेसहरू चाहिँ उहाँहरूले चाहिँ हाइलाइट गर्नुभएको छन् र त्यसै गरी रिकमेन्डेसनमा अब के गर्न सकिन्छन् भन्दा विशेष गरी 3 तह गभर्मेन्टमा चाहिँ कोअर्डिनेसन गर्नु पर्यो ताकि बजेटमा डुप्लिकेसन नहोस् अथवा कुनै पर्टिकुलर सेक्टरमा बजेट नछुटोस् र त्यसको आधारमा 10% कसरी पुर्याउने त्यो कोअर्डिनेसन गरेर लानुपर्ने मन्त्रालय लगायतका लाइन मिनिस्ट्रीहरूको एब्जर्प्सन क्यापासिटी बढाउनै पर्ने कुराहरूलाई जोड दिएका छन् र अर्को भनेको विशेष गरी एडभोकेसीलाई उहाँहरूले फोकस गर्न भएको छन्। त्यसै गरी हेल्थ इन्सुरेन्स र अरू फ्री केयर स्किम्सलाई मर्ज गर्न उहाँहरूले च्यालेन्ज हाइलाइट गर्नु भनेको डिपार्टमेन्ट र मिनिस्ट्रीको रिजिडनेस छन्, उहाँहरूको आफ्नै एक्ट रेगुलेसन छन्, त्यही लिगल फाउन्डेसन्सले पनि यसमा बाधा पुऱ्याएका छन् भन्ने कुरा ल्याएका छन्। काम गर्ने तरिका हाम्रो एकदमै फ्रेगमेन्टेड एप्रोचमा छन् भन्ने कुरा आएका छन्। त्यसै गरी अनक्ल्यारिटी कसको रेस्पोन्सिबिलिटी हो भने अहिलेसम्म कसैबाट इनिसिएसन नभएको र यो अनक्लियर भएको कारणले पनि र अर्को भनेको अनस्टेबल गभर्मेन्ट कारणले पनि यो अगाडि बढ्न नसकेका कुराहरू अगाडि बढाएका छन्। र रिकमेन्डेसनमा हेर्ने भने पोलिटिकल कमिटमेन्ट कुराहरू अब हेल्थ फाइनेन्सिङ स्ट्राटेजी त आइसकेका छन् तर त्यो इम्प्लिमेन्टेसन प्लान अझै पनि बनेका छैनन् भन्छ त्यसलाई इम्प्लिमेन्ट कहिले गर्ने कुराहरू ल्याएका छन् र त्यसै गरी स्टेट रेस्पोन्सिबिलिटी गर्नेदेखि लिएर सोसल सेक्युरिटीको अम्ब्रेला एक्ट बनाउनुपर्छ भन्ने कुरालाई चाहिँ जोड लगाएका छन्। पछि चाहिँ प्रोभाइडर स्प्लिटका च्यालेन्ज हेर्ने हो भने होइन अब कति कुरामा चाहिँ यो मन्त्रालय आफै पनि पर्चेजर प्रोभाइडरको रूपमा रेगुलेटरको रूपमा काम गरेको कारणले त्यो डिभिजन क्लियर रेस्पोन्सिबिलिटी हुनुपर्ने कुराहरू जनाएका छन् र त्यसै गरी एचआइभीमा अटोनोमस अझ पनि हुन नसकेका उहाँहरूको आफ्नै अपरेसन च्यालेन्जेसहरूलाई उहाँहरूले फोकस गर्नु भएको छन् र स्ट्राटेजीमा मेनली क्यापासिटी डेभलपमेन्ट अफ एचआइभी होइन ओएनएम सर्वे हुनुपर्ने र ग्रेजुअल इम्प्लिमेन्टेसन इन्टु पर्चेजर प्रोभाइडर मन्त्रालयभित्र पनि त्यो हुनुपर्छ भन्ने कुरा चाहिँ उहाँहरूले चाहिँ हाइलाइट गर्नुभएको छ। र लास्टमा हेर्ने हो भने एक्रिडिटेसन हाम्रोमा चाहिँ अझ पनि एक्ट ड्राफ्ट स्टेजमा छन् होइन तर हाम्रोमा मेनली भनेको अब एक्रिडिटेसन त गऱ्यौँ कुनै स्वास्थ्य संस्थाको क्वालिटी सर्भिस छैनन् भने हामीसँग रुरल एरियामा अल्टरनेटिभ सेवा दिने हेल्थ फेसिलिटीहरू छैनन् भने चाहिँ कसरी जाने त। र अर्को भनेको केही कन्फ्युजनहरू पनि छन् यसका प्रोसेसहरू हामी खालि हस्पिटलहरूलाई चाहिँ रेजिस्टर मात्र गर्ने हो कि त्यसका क्वालिटीका सर्भिसलाई एक्रिडिटेट पनि गर्ने हो नि त त्यो लेभलमा हामी कुन प्रोसेसबाट जाने भन्ने कुरालाई पनि उहाँहरूको चाहिँ केही रेजिस्टेन्सहरू रहेको होइन लिगल फ्रेमवर्कहरूमा चाहिँ कमी कमजोरी भएका कुरालाई औँलाएका छन् र रिकमेन्डेसनमा विशेष गरी चाहिँ उहाँहरूको जोड भनेको मिडियम टर्म सोल्युसन निकालौँ र आउटपुट बेस्ड पेमेन्टमा जाउँ यो स्यालेरी लाइन आइटम भन्दा नि आउटपुट बेस्डमा जानुपर्छ भन्ने कुरालाई जोड दिएका छन् कन्ज्युमरलाई एकाउन्टेबल बनाउने होइन स्ट्रङ विल बनाउनु पर्छन् भन्ने कुरालाई चाहिँ जनाएका छन्। र यसै सन्दर्भमा अब यो कन्क्लुजनमा भन्नुपर्दा विशेष गरी अब हेल्थ फाइनेन्सिङलाई रिफर्म नै गर्ने हो भने दे आर एम्पल अफ स्ट्राटेजी जसलाई चाहिँ हामीले ब्यालेन्स वेमा चाहिँ हामीले लानुपर्छन्। केही स्ट्राटेजी चाहिँ स्टेक होल्डरको आधारमा हाम्रा कि स्टेक होल्डरले नै बताउनु भएको आधारमा चाहिँ बजेट 10% नै पुर्याउनु पर्ने ताकि इसेन्सियल हेल्थ सर्भिस सबैलाई पुर्याउन सक्ने मर्ज गरेर नै वान डोर एप्रोचमा जाने होइन पर्चेजर प्रोभाइडर मन्त्रालयदेखि सबैमा स्प्लिट भएर चाहिँ क्लियर रोल्स एन्ड रेस्पोन्सिबिलिटी डिभिजन हुने होइन एक्रिडिटेसनहरूका कुराहरू पनि ल्याएका छन् भन्छ यी स्ट्राटेजी हुन् त डेफिनेटली दे आर च्यालेन्जेस होइन च्यालेन्जेसमा हेर्ने भने चाहिँ बजेट कन्स्ट्रेन्टदेखि लिएर पोलिटिकल रेजिस्टेन्सदेखि लिएर होइन यसमा चाहिँ अब कोअर्डिनेटेड एफोर्टहरू चाहिने र त्यसै गरी टेलर एप्रोच ग्रुपमा होइन यसलाई चाहिँ ब्यालेन्स वेमा चाहिँ लानुपर्छन् भन्ने कुरा चाहिँ यी कन्क्लुजन चाहिँ यो स्टडीबाट आएको छन् र यति भन्दै यस म धन्यवाद दिन चाहन्छु। एनी क्वेसन्स?
Thank you, Vikesh, for your presentation. Since we are running out the time as well, I request for the next presenter, Vinita Kumari Podel, and she will be giving the presentation on competency in using a district health information system among health workers in Nepal. Dr. Vinita is Associate Professor at the Purvanchal University College of Medical Allied Sciences. Her field of interest includes the area of like health services, demography, orphan and vulnerable children. With this, I request Dr. Vinita to give her presentation, please.
Thank you, Chairs. Research team को बिहाफमा म NHRC-लाई धन्यवाद दिन चाहन्छु। Competency in using district health information system among health workers in Nepal. Outline of the presentation, background, objectives, methodology, results, conclusion and takeaway message. Background मा जाने क्रममा अघि रवि मिश्र सरले प्रेजेन्ट गर्नुभएकै कुरा यहाँ पनि फेरि दोहोरिएको छ। हेल्थ सिस्टमको जुन WHO को एनालाइटिकल फ्रेमवर्कमा 6 कोर बिल्डिङ ब्लक्स हुन्छन् भनेर छन्, जुन अघि रवि सरको स्लाइडमा थियो। र त्यो मध्येको एउटा बिल्डिङ ब्लक्स हेल्थ इन्फर्मेसन सिस्टम HIS हो। र यो चाहिँ हेल्थ सिस्टमको डिफ्रेन्ट लेभलमा एकदमै युजफुल छ। यो सबै हामीलाई सबै थाहा भएकै कुरा हो। र यसको युज मेनली डिसिजन मेकिङमा, प्लानिङमा, इम्प्लिमेन्टेसनमा, इभ्यालुएसन एन्ड पोलिसी फर्मुलेसनमा युज हुन्छ। थुप्रै स्टडीहरूले के भनेको छन् सिचुएसन एनालाइसिस गर्दा भन्दा हाई पर्फर्मिङ हेल्थ इन्फर्मेसन सिस्टम चाहिँ आवश्यक छ है LMICSमा भन्ने कुराहरू थुप्रैतिरबाट सजेसन आइरहेको छ। त्यस्तै सजेसन अनुसार नै एउटा सोल्युसनको रूपमा DHIS चाहिँ फ्री, फ्लेक्जिबल र ओपन सोर्स प्लेटफर्मको रूपमा डेभलप भयो, जसले के गर्छ भने राइट पिपुललाई राइट टाइममा, राइट फर्मेटमा, राइट इन्फर्मेसनहरू कम्युनिकेट गर्न सक्छ। हस् सर, हस् हुन्छ सर, हस् थ्याङ्क यू। DHIS एउटा अल्टरनेटिभको रूपमा त्यसरी सजेसन भएको छ र नेपालले पनि 2016मा DHIS2 इम्प्लिमेन्ट गर्यो यो हेल्थ इन्फर्मेसन म्यानेजमेन्टको लागि। तर डिफ्रेन्ट रिसर्चहरूले फेरि के पनि देखाएको छ भने फुल्ली क्यापेबल हुनुहुन्न है ह्युमन रिसोर्सेसहरू यो युज गर्नको लागि भन्ने अरू स्टडीहरूले पनि देखाएको छ। र कम्पिटेन्सी फेरि एउटा महत्त्वपूर्ण कम्पोनेन्ट पनि हो। फेरि यो अब सिस्टम युज गर्ने भनिसकेपछि, सफ्टवेयर युज गर्ने भनिसकेपछि कम्पिटेन्सी एउटा अर्को इम्पोर्टेन्ट एस्पेक्ट पनि हो। अनि त्यही कारणले गर्दा कतिपय स्टडीहरूले फुल्ली कम्पिटेन्ट नभएको पनि देखाइराखेको क्रममा हामीले पनि फेरि त्यो कुरालाई अलिक कम्प्रिहेन्सिभ वेमा स्टडी गर्न चाह्यौँ र यसले त्यही कोर कम्पिटेन्सी के छ त भनेर हेर्न खोजेको छ। मेथोडोलोजीमा जाँदा यो प्रेजेन्टेसन खासै पार्ट अफ द रिसर्च प्रोजेक्ट जुन चाहिँ कन्भर्जेन्ट प्यारलल मिक्स मेथड डिजाइन युज गरेर गरिएको रिसर्चको पार्ट चाहिँ प्रेजेन्टेसन गर्न गइरहेको छौँ, जसमा मेनली यो प्रेजेन्टेसनमा फोकस चाहिँ कम्पिटेन्सीलाई मात्रै गरिएको छ, जुन स्मल पार्ट हो तर भेरी इम्पोर्टेन्ट पार्ट हो। प्रेजेन्टेसनलाई फोकस गरेको छौँ। यो प्रेजेन्टेसन प्रिपेयर गर्नको लागि हामीले अथवा यो स्टडीमा हामीले टोटल गभर्मेन्ट हेल्थ फेसिलिटिजहरू जुन दाङ डिस्ट्रिक्टमा भएको 119 गभर्मेन्ट हेल्थ फेसिलिटिजहरूलाई पपुलेसनको रूपमा कन्सिडर गरेर अनि 1 हेल्थ वर्कर फ्रम इच फेसिलिटी, त्यो चाहिँ पनि डेजिग्नेटेड हेल्थ वर्कर जसलाई त्यो स्पेसिफिक रेस्पोन्सिबिलिटी दिएको छ, त्यो हेल्थ वर्करलाई चाहिँ हामीले बाट इन्फर्मेसन कलेक्सन गरेको छौँ। स्याम्पल पपुलेसन र स्याम्पलको कुरा गर्नुपर्दा टोटल हेल्थ फेसिलिटिज अघि मैले उल्लेख गरेँ 119, जसमा 10 वटा हेल्थ फेसिलिटीले DHIS2 युज गरिरहनु भएको रहन्छ। अनि हामीले कम्पिटेन्सी हेर्ने क्रममा चाहिँ अब उहाँहरूलाई एक्सक्लुसन गर्नु पर्यो, एक्सक्लुड गऱ्यौँ, जसमा इलिजिबल 109 मात्रै हुनुभयो। अनि त्यो 109 हेल्थ फेसिलिटीहरूमा हामीले कन्ट्याक्ट गऱ्यौँ, इमेलबाट पठायौँ। अनि विभिन्न इस्युहरूको कारणले गर्दाखेरि हामीलाई रेस्पोन्ड चाहिँ 95ले गर्नुभयो। 95मा चाहिँ 1 हस्पिटल, 2 प्राइमरी हेल्थ केयर सेन्टर, 33 हेल्थ पोस्ट, 25 अर्बन हेल्थ सेन्टर, 9 कम्युनिटी हेल्थ युनिट एन्ड 25 बेसिक हेल्थ सर्भिस सेन्टरहरू चाहिँ 95मा टोटल चाहिँ त्यति हुनुहुन्छ। डेटा कलेक्सन टुलमा हामीले कम्पिटेन्सीलाई सेल्फ रेटेड गरेको थियौँ, त्यसो भएर सेल्फ रेटेड वेब बेस्ड क्वेसनर प्रिपेयर गरेको थियौँ र त्यो क्वेसनर वेब बेस्ड क्वेसनरको लिङ्कलाई हामीले इमेलबाट पठाएको थियौँ, जुन डेजिग्नेटेड हेल्थ वर्करको इमेलमा हामीले पठाएको थियौँ र फोनबाट चाहिँ फलोअप गरेको थियौँ। अनि उहाँहरूले भरेर पठाउनु भयो, भरेर पठाउन नसक्नेहरूले चाहिँ अब किन सक्नु भएन, फोनबाट सम्पर्कहरू चाहिँ भइराखेको थियो। यो स्टडीमा डेजिग्नेटेड हेल्थ वर्कर भनेर चाहिँ को हुनुहुन्थ्यो त भन्दा जसलाई त्यो जिम्मेवारी दिएको छ उहाँ हुनुहुन्थ्यो। उहाँहरूमा स्ट्याटिस्टिसियन, मेडिकल अफिसर, हेल्थ एसिस्टेन्ट, सिनियर स्टाफ नर्स, पब्लिक हेल्थ अफिसर, हेल्थ इन्फर्मेसन म्यानेजर अफ हस्पिटल, सिनियर एएसडब्ल्यू, एएनएमडब्ल्यू, त्यस कारणले डिफ्रेन्ट यो एकदम डिफ्रेन्ट पिपुलहरू प्रोफेसनल्सहरू चाहिँ हुनुहुन्थ्यो। अनि त्यो एक्सेलबाट एसपीएसएसमा एक्सट्र्याक्ट गरेर डेटा एनालाइसिस गरिएको थियो। रिजल्टमा जाँदा सोसियो डेमोग्राफिक क्यारेक्टरिस्टिक्सको कुरा गर्नुपर्दा फिमेल भन्दा मेल धेरै हुनुहुन्थ्यो, 68% मेल। एजमा नर्मली 20 to 34 एज ग्रुपको 43%, अलमोस्ट हाफ हुनुहुन्थ्यो। वर्क एक्सपिरियन्स मोर देन 10 years वर्क एक्सपिरियन्स हुने 44% हुनुहुन्थ्यो। त्यस्तै एजुकेसनको दृष्टिले हेर्दा टीएसएलसी गर्ने 33%, 1/3 चाहिँ टीएसएलसी गर्नुभएकोहरू हुनुहुन्थ्यो। युनिभर्सिटी डिग्रीमा अलमोस्ट 1/3 हुनुहुन्थ्यो। अनि जब लेभलको कुरा गर्दाखेरि अब 6th लेभलको चाहिँ 54%, मोर देन हाफ चाहिँ 6th लेभलको हुनुहुन्थ्यो। अनि पर्मानेन्ट चाहिँ 76% हुनुहुन्थ्यो भने अलमोस्ट अल नै प्यारामेडिक्स, केही नर्सिङ हुनुहुन्थ्यो। हामीले क्वेसन कम्पिटेन्सीको क्वेसन सोध्ने क्रममा एक्सेसको कुरा गरेको थियौँ। अफकोर्स एक्सेस त सबैजना युज गर्नेहरूको हुने भयो, 100%ले नै एक्सेस छ, उहाँहरूको एकाउन्ट छ, युजर एकाउन्ट भन्नुभयो। किनभने युजर एकाउन्ट नहुनेहरू त अलरेडी एक्सक्लुड पनि हुनुभएको थियो। अनि ट्रेनिङ पाउनु भएको छ कि छैन भन्दाखेरि 78.9%ले चाहिँ ट्रेनिङ पाएको छौँ। जुन DHIS2 डेटा एनालाइसिसको ट्रेनिङ पाउने 78.9% हुनुहुन्थ्यो। हामीले DHIS2 को कम्पिटेन्सी हेर्ने क्रममा कम्प्युटर स्किल त बेसिक स्किल नै हो, त्यो त अफकोर्स हेर्नुपर्छ भन्ने लागेर हामीले यो कम्प्युटर स्किल को पनि क्वेसन राखेको थियौँ। के छ भनेर बेसिक कम्प्युटर अपरेसनको स्किल के छ भनेर हामीले चाहिँ सेल्फ रेटेड क्वेसनर जुन 4वटा लेभलमा नन, बेसिक, एभरेज, एडभान्स भनेर हामीले सोधेको थियौँ। अनि त्यसमा बेसिक कम्प्युटर अपरेसनको स्किल छैन भनेर नन भनेर 8.4%ले, अनि जस्तो भेरी सिम्पल क्वेसन बेसिक कम्प्युटरमा हामीले चाहिँ फाइल म्यानेजमेन्ट, ओपन सेभ गर्ने कुराहरूमा पनि 15.8%ले चाहिँ नन भन्ने रेस्पोन्स आयो। त्यस्तै क्यापेबिलिटी अफ वर्किङ अन स्प्रेडसिट पनि 41.1%ले नन भन्ने चाहिँ रेस्पोन्स आयो, जुन चाहिँ अलिकति सरप्राइजिङ पनि हो हैन, र सायद इम्पोर्टेन्ट पनि होला। त्यस्तै कम्प्युटर स्किलमा पावर पोइन्ट प्रेजेन्टेसनको पनि 22.1%ले नन भन्नुभयो। त्यस्तै इन्टरनेट सर्फिङ सर्चमा पनि 14.7%ले नन भन्नुभयो। इमेल कम्युनिकेसनमा 11.6%ले नन भन्नुभयो। हुन त त्यो नेटको चाहिँ फेरि रेस्पोन्स चाहिँ गर्नुभएको छ है फेरि, तर उहाँहरूको अप्सनमा चाहिँ यसरी आएको छ। अनि त्यस्तै त्यस पछाडि हाम्रो कम्पिटेन्सीमा सेल्फ रेटेड कम्पिटेन्सी DHIS2 को कुरा गर्दा DHIS2बाट नेभिगेट गर्न सक्नुहुन्छ कि हुन्न भन्ने कुरामा त्यसमा चाहिँ हाई, मोडरेट र लो भनेर हामीले सोधेको थियौँ। त्यसमा चाहिँ 70% को चाहिँ हाई, त्यस्तै डेटा इन्टर गर्नेमा 100% नै थियो। मेनली उहाँहरूले युज चाहिँ डेटा इन्ट्री चाहिँ सबैजनाले चाहिँ गर्न सक्ने क्यापेबिलिटी चाहिँ त्यो चाहिँ हामीले देख्यौँ। अनि भ्यालिडेसन गर्ने पनि 86%मा चाहिँ हाई थियो, एनालाइज गर्ने 67%मा हाई थियो। त्यस्तै DHIS2लाई रिपोर्टिङको लागि युज गर्ने चाहिँ फेरि 100% नै आयो। यसमा चाहिँ सायद उहाँहरूले मिसअन्डरस्टुड, रिपोर्टिङ भन्दाखेरि त्यो डेटा इन्ट्री गरेर पठाउनेलाई मात्रै आज रिपोर्टिङ बुझ्नु भएको हो जस्तो लाग्यो यसमा चाहिँ हैन, किनभने रिपोर्टिङको लागि त फेरि भ्यालिडेसन, एनालाइसिस पनि, भिजुअलाइजेसन पनि आवश्यक पर्छ, तर रेस्पोन्स चाहिँ यसरी आएको छ। अनि डेटा प्लानिङमा 65% को हाई छ भने डेटा फिडब्याक प्रोभाइड गर्नलाई चाहिँ 64%मा हाई कम्पिटेन्सी छ, र DHIS2लाई पोलिसी डिसिजनमा 56.8%ले हाई कम्पिटेन्सी छ भनेर भन्नुभएको छ। र त्यसमा चाहिँ लो, विशेष गरी जति स्किल बढ्दै जान्छ त्यसमा चाहिँ लोमा पनि प्रोपोर्सन चाहिँ बढ्दै गइराखेको छ। DHIS2 को डिफ्रेन्ट एस्पेक्टमा युज गर्ने क्रममा चाहिँ लोमा पनि बढ्दै गइराखेको छ। र यो फाइन्डिङ्सको खास कन्क्लुजन चाहिँ के हो त भन्दा अघि हामीले अलरेडी एक्सक्लुड गऱ्यौँ, एक्सक्लुड गरेको केसलाई चाहिँ छोडेर हामीले जसलाई इन्क्लुड गऱ्यौँ, इन्क्लुड गरेकोमा हेर्दाखेरि 1 out of 4 हेल्थ फेसिलिटी स्टिल डोन्ट ह्याभ ट्रेन हेल्थ वर्कर अन DHIS2। मैले सकि नै हालेँ, अब लास्ट स्लाइड हो बाँकी। अनि हेल्थ वर्कर हु आर ट्रेन एन्ड युजिङ DHIS2 डु नट फिल कम्पिटेन्ट, यो सेल्फ रेटेड क्वेसनर हो, उनीहरू कम्पिटेन्ट फिल नगर्नु भनेको कन्फिडेन्ट पनि नभएको रूपमा पनि हामी लिन सक्छौँ। अनि त्यसको कारणले रिफ्रेसमेन्ट ट्रेनिङ सायद अनसाइट कोचिङहरू चाहिँ आवश्यक छ भनेर हामी सजेसन रिकमेन्डेसन गर्न सक्छौँ। बट एट द सेम टाइम टेक अवे म्यासेजमा म चाहिँ के भन्न चाहन्छु भने अब गभर्मेन्टमा काम गरिरहनु भएको कर्मचारीहरू हुनुहुन्छ, डिफ्रेन्ट लेभलको हुनुहुन्छ। अब अहिले हाम्रो 80s मा भएको प्यारेन्ट्सहरूले पनि अहिले सिकेर मोबाइलहरू सबै कुराहरू चलाउन जानिराख्नु भएको छ भने यहाँनिर मैले चाहिँ के फिल गरेँ भने अलिकति सेल्फ लर्निङको इन्ट्रेस्टहरू पनि जगाउनु पर्ने हो कि ट्रेनिङ पाए मात्रै हामी गर्न सक्छौँ भन्ने खालको भावलाई चाहिँ हामीले अलि डिमोटिभेट गरेर अनि कसरी हामी त्यसलाई चाहिँ मोटिभेट सेल्फ लर्निङमा, किनभने एभाइलेबल छ एभ्रिथिङ अहिले इन्टरनेटमा, अनि त्यो कुरालाई पनि हामी इन्करेज गर्न सक्छौँ कि कसरी गर्न सक्छौँ त फर्दर हामीले त्यो विषयमा चाहिँ सोच्नुपर्छ जस्तो लाग्छ। गभर्मेन्टले दिने ट्रेनिङमा मात्रै डिपेन्डेन्ट हुनुपर्छ भन्ने छैन अहिले सिक्नको लागि, अनि टेक्नोलोजी अनुसार हामी त्यो क्यापासिटी जस्तो लाग्छ। धन्यवाद।
Thank you, Vinita ji, for your presentation. Now we have a next presentator, Pavitra Nyapane, and she will be talking on readiness of health system to provide a disability-inclusive health services in a Karnali province of Nepal, a perspective from the service providers and women with disabilities. Pavitra ji, please. Yeah.
Thank you, sir, and namaste to everyone. With the permission of chairs of today's session, I would like to start my presentation. And the title for my presentation is Readiness of Health System to Provide Disability-Inclusive Health Services in Karnali Province of Nepal, a perspective from service provider and women with disabilities. Now I would like to start with the contents of the presentation. Here you can see in the slide. And then let's start with the background and objective of the my presentation. And in total, 2.2% population of Nepal are living under some kind of disabilities, and out of that, 42.8% are females. And women with disabilities have like need for general and specialized health services, but according to the various research findings, it has shows that their service utilization is limited due to the attitudes and behavior of healthcare providers and other geographical and infrastructural barriers as well. So there has been very limited studies that has explored the readiness of health system to provide the disability inclusive services. So through this study, we have aimed to explore service readiness among health institutions in Surkhet and Mugu districts of Karnali province of Nepal to provide disability inclusive health services. So we have taken two municipalities, that is Birendranagar municipality from Surkhet and Chayanath Rara municipality from Mugu district. Moving toward the methodology, we conducted a qualitative study by using thematic analysis, and we also took ethical approval from Nepal Health Research Council for the study. And we conducted purposive sampling among 35 participants, out of which 7 were in-depth interview with women living with disabilities to understand the context, and 20 were key informant interviews with health service providers, and then we have one FGDs with healthcare providers of 8 participants. Going towards the data collection, we also observed 10 health facilities following the guideline of WHO and then a National Federation of Disabled Association as well. And then we used semi-structured interview guideline and observation checklist for the data collection as a tool. And then the interview were stored in online so that we can prevent the data loss as well. Now, for the data analysis, we performed inductive coding using DDoS, and we generated codes, sub-theme, and themes from the collected data. Then we conducted latent analysis to interpret the collected data. So here is the result of this study. Here you can see the theme and sub-themes of this study. We have 3 major themes and 10 sub-themes. And then within first theme there is 4 sub-themes, and within second theme there are 3 sub-themes, and within third theme there are 3 sub-themes. So let's start with the theme number 1, barrier in accessing health services. So during the observation and in-depth interviews and KIA with healthcare providers and women with disabilities, we found that there was no tactile footpath, ramp, or accessible railings, and accessible gender-friendly toilets, signages, and other necessary equipments in the health institutions that were required to provide disability-inclusive services. And we also came to know from the in-depth interview with women with disabilities that healthcare providers had inappropriate behavior or discriminatory behavior among women living with disabilities, as when they went to seek services, they were asked about their need of contraceptive devices or any doses of the medicines, and even they were not invited in the programs and workshops related to the health services. Yeah. It's similar to previous health services. Health service providers also showed some of the negative attitude towards the women living with disabilities while going to seek for the services. And regarding this, we also cross-checked with the healthcare providers, and their response was that sometimes women with disabilities or persons with disabilities seeking healthcare services misunderstand the other service provider of the hospital with healthcare providers. So. Lastly, we have sub-theme centralized service provision, and the services were provided through health institutions. Let's say it was centralized in health institutions, due to which women living with disabilities were not able to access health services due to their physical condition or disability status and geographical barriers. So decentralization of it necessary through mobile clinics, health camps, or online services. So here is some excerpts that depict the findings of these themes. Here I want to go with one. There was not any health post near or during my pregnancy. I needed to walk a long distance using a crutch. Thus, I knew the information, but I did not go for the service. The path near the health post is very bad, so I feel difficulty. The health post is far away from the village, and I need to walk for a long distance to reach the health post. It was said by women with disability from IDI. So this depicts the readiness of our services, health services as well. So theme number 2 is knowledge and skills of healthcare providers. So we did FGD and KIA with healthcare providers, and the findings are here. So majority of the healthcare provider did not receive any comprehensive clinical information, whether it be their medical school or prior to the service. And service providers also shared that sometimes they relied on the observation without consultations with the persons with disabilities who come to seek services, as they do not have skills to communicate with them. And another is disability management and procedural skills. Majority of the healthcare providers also accepted that they lack procedural knowledge and skills in treating persons with disabilities, because they do not have they didn't receive any kind of trainings related to the issue, though there is the guideline of disability inclusive services in Nepal. So next is communication skills. Majority of the healthcare provider also identified that whether there is necessary of them to learn sign languages, or there should be provision of keeping sign language interpreter in the hospital, so that they can provide services to the women with disabilities or persons with disabilities in a better way. Here is one excerpt. One, I had an experience of counseling a woman with disabilities for ANC who couldn't respond quickly and couldn't speak. Then I asked to come up with her husband next time. It was said by female auxiliary nurse from KII. It is the context where she sent back to the patient who worked for hours to come to the health institutions. So it depicts how communication barriers are creating the difficulties for persons with disability to access the healthcare services. Now we have theme number 3, disability inclusive policy and governance. Not only negative, there were of course some of the healthcare providers who also prioritize persons with disabilities while providing services by understanding their specific needs in their healthcare settings, by like not letting them to be in queues or emergency wards, and suggesting or supporting them to go in different wards to ensure that they receive timely and appropriate services. Now we have next theme, and majority of participants also highlighted that there will be integration of the plans and policies in the local and provincial governments, red book or any strategies for the disability inclusive health services. And lastly, we have majority of the participants also highlight that there needs to be provision of budget to procure disability specialized tools and equipments and skilled human resource in the health institutions for the readiness of disability inclusive health services. So here is one excerpt from the medical officer from KII. So with the conclusion that as we see, I am focusing women, though it's only persons of disabilities, because context is that women are facing a lot of difficulties to access healthcare services in rural settings. So women with disabilities face intersecting challenges in accessing any kind of health services because of healthcare providers' behavior and attitudes, as they also do not have adequate knowledge and skills in providing disability inclusive health services due to information and lack of trainings. And so it is essential to ensure disability inclusive health infrastructure and increase the competency among healthcare providers for disability management and procedural skills, and for the interpersonal communication skills, and to provide gender sensitive healthcare services among the persons with disabilities as well. Lastly, we need to also there should be a policy with adequate budget provision to implement the disability health programs. I'll complete. So the takeaway from this presentation is, or this study is, there should be a comprehensive ecosystem for health service readiness among health institutions from Karnali province of Nepal for disability inclusive health services for women with disabilities, as they face intersecting and multifaceted challenges to receive the healthcare services. Here are some of the references that we used. Thank you very much.
Thank you, Pavitra ji, for your presentation. With that, we'll move for next presentation will be delivered by Shaugat Pratap KC, and his presentation is Health Facilities Readiness to Implement Standard Precautions for Infection Prevention and Control in Nepal, a secondary analysis of Nepal Health Facility Survey 2021. Saugat, please.
Respected chairs, fellow presenters, and everyone present in this hall. On behalf of my research team, I'll be presenting on the topic Health Facilities Readiness to Implement Standard Precautions for IPC in Nepal. It's a secondary analysis of Nepal Facility Health Survey. So without further delay, I'll get to the context. So healthcare-associated infections are a major concern globally, and it incurs a significant economic burden and mortality rates, and this is more in the LMIC settings. Up to 70% of healthcare-associated infections can be prevented through effective prevention infection prevention and control measures like hand hygiene and proper equipment sterilization. Despite the healthcare coverage expansion, quality of care hasn't improved proportionally, and few healthcare facilities globally meet the minimum IPC requirements. Implementing standard precautions, including IPC measures, is crucial for patient safety, healthcare-associated infections, and healthcare worker well-being. National IPC guidelines and implementation manuals, such as those launched by the Ministry of Health and Population in Nepal, plays a vital role in standardizing IPC practices and achieving the Sustainable Development Goal 3 for universal health and well-being. Now, moving to the objective of the study. The first objective of the study was to assess the readiness of health facilities to implement standard precautions for IPC in 8 service delivery domains. And as part of a note, I've listed the domains at the bottom of the slide. And objective number 2 is to determine association of readiness of health facilities to implement standard precautions for IPC with the characteristics of health facilities. Going to the methodology of the study, this study is, the study design of the study was secondary analysis of National Health Facility Survey 2021 data. And moving to the variables, the dependent variable of the study is the readiness score to implement standard precautions for IPC. This was based on the Service Availability and Readiness Assessment Manual using 8 tracer items, and you can see the listed 8 tracer items. That is guidelines for standard precautions, latex gloves, soap and running water or alcohol-based hand rub, single-use disposable auto-disabled syringes, disinfectant, safe final disposable of sharps, safe final disposable of infectious waste, appropriate storage of infectious waste. And for the independent variable of this study, we looked at the location, the rural-urban category, ecological region, province, facility type, presence of external supervision, quality assurance activities, frequency of health facility meeting, and review of client's opinion. For the statistical analysis, we performed a weighted analysis to account for the complex survey design in our program. For the study, we applied a quantile regression analytical approach to evaluate the association between characteristics of health facilities and IPC readiness across scores with a set of quantiles ranging from 0.1 to 0.9. And the results were presented as beta coefficient and their 95% confidence interval. Now moving on to the results of the study. We'll be talking briefly about the characteristics of the health facilities. Majority of the health facilities were local health facilities, accounting for 90.8%, followed by private hospitals, 7.4%, and federal or provincial hospitals, 1.8%. So out of 1,565 health facilities, 52.3% of them were from hilly region, and then followed by Tarai region, accounting for 34.2%, and 13.4% from the mountain region. And from province, the health facilities were, the proportion of health facilities were majority from Bagmati province, accounting for 20.5%, and the least was from Karnali province, accounting for 8.2%. In terms of availability of services, in the federal or provincial hospitals, as you can see, majority of the health facilities have all these services, but child and adolescent vaccination services was the least, accounting for 73.2%. And in all health facilities, delivery and newborn care services was the least, accounting for 51.4%. Now, this table talks about the readiness score of health facilities for standard precaution for IPC. And you can see in all the health facilities, tuberculosis care area was the least with 55.5. That's the score. And the overall score of all health facilities was 59.8. In this visual representation, we see the distribution of IPC tracer items for different service delivery domains. And the guideline for IPC was the weakest domain, followed by medical waste disposable in each service delivery domain and each type of health facility. And latex gloves, disinfectants, soap and water, alcohol-based hand disinfectants were the most. So now this visual representation is a bit complex, and I'll try to explain in the best way possible that I can. And I'm sorry if it's not too visible. So in this figure, the gray color that you see represents the confidence interval of beta coefficient from quantile regression. And the black dotted line that you see in the graph over there represents the beta coefficient from different quantiles. The red bold line represents beta coefficient from the linear regression results. And the red dotted line represents the 95% confidence interval from the linear regression result as well. So as per the result, we see that the readiness score of local health facilities was significantly lower than federal or provincial hospitals in all quantiles, ranging from 0.2 to 0.8. The facilities with quality assurance activities have higher readiness score at all quantiles between 0.3 and 0.7. The facilities with the mechanism of reviewing client's opinion have higher readiness score in quantiles ranging from 0.3 to 0.6. Now, this is my conclusion of my presentation. The readiness of health facilities to implement standard precautions for infection control was high, but leaves room for improvement, and this can be accounted for prioritizing allocation of human resource and also improving the health infrastructure. The health facilities performing quality assurance activities, health facilities with mechanism for reviewing clients' opinion, and health facilities from Bagmati, Gandiki, and Karnali province had a higher readiness score to implement standard precaution for IPC. The results can support policymakers and stakeholders to make informed decisions to improve overall infection and prevention and control measures. This will enable the healthcare system to better respond to emerging health threats. Thank you very much.
Thank you, Sagat, for the presentation. Now, I would like to invite next presenter, Sunil Shrestha, please. And his presentation is Comprehensive Assessment of Pharmacist-Driven Interventions on Pain Outcomes, an umbrella review of systemic reviews and meta-analysis. Mr. Sunil, please.
Thank you, Chair. Myself, Sunil Shrestha. Today, I am going to present on comprehensive assessment of pharmacist-driven intervention on pain outcome. It is an umbrella review of systematic reviews and meta-analysis. I don't have any conflict of interest related to this research. Acute and chronic pain presents a significant public health concern which affects the millions of individuals. Pain is one of the prevalent and challenging healthcare issues. Pain management involves a multidisciplinary approach where various healthcare professionals are involved in the management of the pain. Among these healthcare professionals, pharmacists have emerged as a valuable contributors. They have a unique skills and expertise that can optimize pain outcomes. The role of the pharmacist as a medication expert in pain management is widely acknowledged. There are numerous studies which have highlighted the contribution of the pharmacist in providing evidence-based intervention and ensuring the safe and effective use of analgesics. There are several systematic reviews which have studied pharmacists' role and their contribution to the pain management. With the quantity of the systematic reviews investigating the pharmacist's intervention in the pain management, there is a necessity to systematically identify, rigorously evaluate, and combine these findings through an umbrella review. So with this background, we have With this background, we have conducted an umbrella review with an objective to systematically review, publish systematic reviews with or without meta-analysis, investigating the impact of pharmacist-delivered intervention on pain-related clinical, humanistic, and economic outcomes. Before conducting this trial, before conducting this umbrella review, we have registered this in the Prospero. We developed a comprehensive source strategy and implemented to identify relevant systematic reviews from inception to the June 2023. We have sourced 7 electronic databases, including the Central and the DARE. This is the figure of the Prisma diagram, which shows the result of the entire source, screening, and the selection process. We screened more than 2,000 research articles from the different electronic database. After screening and after assessing for the eligibility, we have included 11 studies in the final umbrella review. 11 systematic reviews were included in this umbrella review, which was published between the 2011 and 2023. The included original studies were conducted in the high-income countries such as US, Canada, and some of the European countries, and some were conducted in the Asian countries, China and Japan. The included studies were conducted in the various settings: hospital, clinical, community, pain clinic, and palliative care. Majority of the studies were, majority of the pain type were non-cancer pain, which was followed by the cancer pain, and 18% were the mixed type of pain, which include both cancer and non-cancer pain. Medication review was the most delivered intervention by the pharmacist, which was followed by the patient education, counseling, adverse drug reaction detection and management, non-prescription drug recommendation, and behavior intervention. The other intervention delivered by the pharmacists were the dosage adjustment, referral, interdisciplinary collaboration, psychiatric consultation, pain assessment. Now coming to the clinical outcomes, with an intervention by the pharmacist, there was a decrease in the pain intensity and pain was relieved. Medication adherence was found to be improved. There was the reduction in the adverse drug reaction and drug-related problems. Physical functioning and the mental health of the patient were found to be improved. And there was the length of the hospital stay was found to be decreased. Now coming to the another outcome, humanistic outcome, with an involvement of the pharmacist, there was the improvement in the quality of life of the patient. Patients were more satisfied. There was also increase in the knowledge of the patient. Also, physicians who are working with the team were also satisfied with the pharmacist. Now, coming to the economic outcomes, we have the mixed result. One study shows that there was a decrease in the healthcare costs. However, in one study, it was found that there was an increase in healthcare costs. So future studies can be done in the economic outcomes. Now, findings from the meta-analysis of the included systematic reviews, there was the significant reduction in the pain intensity due to the pharmacist's intervention. Also, there was an improvement in the physical functioning, and quality of life improvement was found. We have used NSTAR2 for the methodological quality assessment. Most of the included studies were determined to be the high quality. Now, limitation of this study. The inclusion criteria encompasses the both systematic reviews involving randomized control trial and the observational studies, which potentially leads to the variation in the strength of the evidence. Another limitation is that this study, since there is a variability in the methodology and the reporting standard, this study may introduce bias. Also, The most of the studies were in English, so we have explored studies which were published in other languages. Now coming to the conclusion and take-home message, pharmacists delivered intervention including the medication review and patient education have a positive impact on the pain management. This umbrella review highlights there is a critical need to establish standardized rules for the pharmacists in the pain management to maximize effectiveness of this intervention. Future research should focus on exploring innovative care models such as pharmacist-independent prescribing within collaborative care clinics dedicated to the pain management. Here are my references. I would like to acknowledge my study team, and thank you so much.
Thank you, Sunilji, for your presentation. I would like to invite next presentator, Sriman Sharma. It is a topic of presentation. Is a health system resilience capacity in federal context of Nepal. Findings from mixed method study. Mr. Sriman, please.
Hello. Thank you, chairs, and thank you, audience. We have quite a long day, and I'm glad to see you are still in the hall. And please bear with me because I guess I'm the last presenter of the day. So the title of my presentation is Health System Resilience Capacity in the Federal Context of Nepal. Findings from the Mixed Method Study. You can see the list of the authors, and my name is Sriman Sharma. I'm one of the contributors. So I would like to start with some of the concepts around the health system resilience found in the existing body of the research, primarily focusing on 3 points around health system resilience. So health system resilience is a concept that is primarily associated with the strength of health system. And first is, health system can be strong in the stable condition, but it doesn't mean that even the strong health system may not respond to the shocks very well. On the other, poor performing or underperforming health system in the normal circumstances can even perform better. So, health system resilience is not very straightforward. And the third point is health system resilience is associated with the strength of the system itself. And it is ongoing process. There is no any completeness for the health system to be resilient. So this notion closely links with the objective of our research in the Rebuild for Resilience project. Rebuild for Resilience is the multi-country research project, and HORD International is one of the partner, and the study is implementing in Nepal as well. So this is the guiding framework of our study, and in the interest of time, I'm not going to elaborate it. So there are many objectives in our study, but particularly the study I'm presenting here aims to map the resilience capacity of the local health system. And largely, our study is focused in one of the municipality in the Kapilvastu district of Lumbini province. We call our study site as a learning site. So as a method, we have employed a mixed method in our study that includes the review of different policy documents and consultative meetings, KII with ranges of the stakeholders that includes local health system stakeholders, especially the policy actors, health workforce, and close to community workers, as well as the representatives from the non-public sector. And we have also gained some insights from the secondary data, especially analyzing the disaster record from 2017 to 2023. And we also conducted health facility assessment in 13 health facilities of that particular municipality. And we also gain insight from the minimum service standards assessment as well as quality data, routine data quality assessment. So the results are here, but before presenting the results, one of my fellow colleagues who is sitting behind suggested me to put forward a disclaimer with the audience, and the disclaimer is that we have become a bit critical in presenting the findings, but take it as a neutral findings, because the objective of our research is to identify the gap, and whenever we present the gap, sometimes it looks a bit critical, so apology for that. So this picture illustrates the risk of different district in terms of the hazards, and you can see the most of the districts which are located in the hilly area and tri-belt, southern part, they are more vulnerable from the perspective of hazard. And you can see here Kapilavastu district somewhere here. The Kapilavastu district is moderately vulnerable in terms of the incident count as well as the economic loss. But when it comes to the death, so it has high risk. So this provides the national picture and illustrates the hazard risk by the district. You can see the majority of the district have the moderate disaster risk. But there are a few of the districts which are at very high risk, both from the perspective of economic loss as well as from the mortality perspective. So these are some of the common shocks that we found in our learning sites. And we have categorized different types of shocks that we found during our study. The first type of shocks was the short kind of shocks that included the vehicle accident, short outbreaks like measles, eye infections. And second, also the long-term shocks like COVID-19. And then we also found the seasonal shocks like floods, inundations, fire, displacement, seasonal diarrheal disease outbreak, which we have listed as the short repeated shocks. And we also found different stressors like climate change, increasing burden of NCDs, and unchecked border crossing as a chronic health system stressor. And we also found some of the factors like resource poor setting, poor linkage between information system and planning, as that led to the chronic health system, that makes the health system dysfunctional. So in the domain of human resource for health, we found that there was a mismatch between demand and supply. For example, in one of the health facility that where we found that 2 health workers were catering to the needs of 9,000 population, but on some other health facilities, same number of the people were serving very less number of people compared to this number. And the unfulfillment of the sanctioned position has remained also as a major problem. And another is the capacity. Given the constitutional right, the local health system have been given, or the functions they are entitled to, there have been gap in terms of the leadership, governance, and management. And another area is the motivation when it comes to the human resource management. So we found that in our learning site, the conventional way of rewarding people and providing incentive was quite common, but intrinsic motivations, for example, like providing the job placement in their preferred positions and providing them exposure, were very instrumental to motivate their staffs. Yeah. And in the here are some gaps in 4 areas. One is the constitutional power without capacity. Largely local capacity is something which is frequently raised because local government have been overwhelmed with the autonomous right they have been given, but they lack the capacity. And another important aspect is planning role with a limited decision space, because local health system is overwhelmed by the programmatic activities from the federal government, and they have limited planning roles. And on the financial aspect, 2/3 of the budget goes as a conditional grant, which has to be spent as detailed out by the federal government. So there is limited space for the local government to have flexibility in the budgetary arrangement. So in the interest of time, I'm going to tell you two stories which are very important from the perspective of health system resilience. That's why I want to, yes. So coordination and collaborations, which is repeatedly cited everywhere. So this is not just a fancy terminology, but very practical when it comes to serving the people. So here is an example. So in the learning site where we work, the municipality thought that if it spent 10 million rupees for the installation of oxygen plant, then people will get service from there very easily. And they allocated budget for the installation of the oxygen plant in the hospital, previously we called district hospital. And the hospital falls in the jurisdiction of the Lumini provincial government. And Lumini provincial government did not provide human resource, and even the lab facilities were poor. And ultimately, the people from Kapilvastu had to travel some 50 kilometers away from their hometown, right? So sometimes coordination, seems very fancy term, but it has implications to the life of the people. That's why I'm trying, that is something that I want to convey from this story. And another story, so another story is when the whole country was grappling with the COVID-19, and of course, the local health system had pressure to respond the pandemic as well. So municipal office decided to use the schools for quarantine during COVID-19 pandemic. But unfortunately, school did not have wash facilities, including toilet and drinking water, right? And quarantine program was not effective and disease spread rapidly. The message is very clear. The notion of multi-sectorality has been missing somewhere in the local health system. So that is very crucial for health system to be resilient. Okay, so here are some conclusions that we have drawn from this study. Of course, the first is there are several areas of improvement for the local health system, for example, in the area of human resource and routine information system, as well as surveillance and leadership and management. Second is, of course, local government are autonomous. There is high degree of autonomy, but at the same time, there are limited flexibility as well. And third, so even if the local government has resources or even human resource, it alone cannot be resilient until and unless there is coordination among three-tier government, as I previously demonstrated in a previous slide. And finally, the notion of multi-sectorality that was largely missing in our learning site, which is very crucial for the health system to be resilient. Thank you.
He was the last presenter, so good that to listen all the presentation. I would like to request Dr. Dipendra Raman Singh, our additional secretary, to have his remarks on the presentation delivered by the fellow presentators. Please, Dr.
Thank you, sir. Indeed, very impressive, very thought-provoking research presentations. I congratulate all the presenters. I guess young researchers, I would say. So one of you are senior ones as well. Basically, it is very pertinent parallel session, I would say, efficient and responsive health system, quality and equitable health services. So these almost 8 presentations comprehensively covered each and every part of the system. The first one, we miss Dr. Sapkota, but Ravi, one of the most diligent young colleagues of mine, beautifully present the system we have, and he took us through the different period of time and how we experience the efficiency as well as the responsiveness of our system. And he also talked a little bit about some indexes. I think we need to carry on assessing how responsive we are and at the same time how efficient we are. Colleagues, I won't take much time. All presentations and all resources, in particularly, you know, the last one actually made us think over, you know, what framework we need to design for our coming days. And almost be it the disability related readiness of our services, be it about the pain management. I'm really, you know, impressed by the way, you know, the research is done, and I really take it very positive, because I also urge all of you to go through the documents we have produced, because, you know, we have made a lot of acts, guidelines, but if we don't go through it, you know, we will miss something. So I urge all of you, young researchers, and at the same time, you know, the financing itself, you know, very impressive. Definitely, from my side, I will take all these pertinent issues raised, and in direct suggestions through all your presentation, I will collect it and will send it to my senior policymakers, and we will definitely discuss on this part how best we can incorporate these suggestions in upcoming plannings. And the last one, I would like to, you know, share with you the resiliency, you know, whether our system is hyper-resilient in some part, or okay resilient, or, you know, hyper-resilience. This has to be, you know, has to be assessed, and this tool, if we can make a very good tool on this, we can bring all the sectors together, you know, as multi-sectorality for resilient health system is a must. And these are all I noted. There are many more. In interest of time, I will make it short. You know, I mean, would like to hand over to my respected teacher and chair of this session to provide his concluding remarks and conclude these sessions. Thank you. Over to you, sir.
Thank you, Dr. Raman. You know, he has given a very comprehensive overview of all the presentations. My observation, you know, for last many years, to see all the, mostly the, I would say that young researchers, you know, in the morning also, mostly the issue of the health policy and implementation, you know. So there are some good policy, there are issues in the implementation, but, you know, these researches, however, these are in a smaller scale has been done. There is some limitation with the sample size, covering the larger area of the population, but very relevant, very useful. Even some may be useful in the provincial level, some may be, I will say that greater address the national level as well, you know. And our additional secretary rightly stated that, you know, all the presentations are very good, and he will bring these presentations to the policy maker and need to be reflected, you know. And we like to have this kind of the research in the future as well. We are doing some kind of the researches, and then these researches are able to bridge the gap, with the program and useful for the program for the future implementation. With that, I would like to congratulate, everybody is tired with the entire day. Congratulate all the presentators, and I have taken is that very useful session. Our additional secretary has taken it very positively to take for the action, for the implementation, Whatever the research we are doing, if we can implement, the implementation research. Basically, I can see that mostly these are the implementation research, and these are the need-based policy type of the things which will guide to the program in the future. So with that, I would like to sincere thanks to the Nepal Health Research Council for the commendable job has done, I have the observation that, earlier also this kind of the summit were done, but this time has done in a big way in the health agency. So I would like to give my sincere thanks to all the management from the Nepal Health Research Council for this organizing important events, and all the presentator fellow and all the distinguished, all the participating in the last hours. I can see the attention of all the participants to listen. So thank you, and congratulations to all the participants. Thank you.
Thank you, chairs, and all the amazing presenters. I request all the presenters to come up in the stage for a group photo opportunity. With this, we've come to an end of the day one presentation and discussion. It's been an amazing day, learning, relearning, and unlearning. Thank you, everybody, for your uninterrupted attention. We'll meet again tomorrow with some exciting presentation and heating discussions. See you tomorrow. Please get some good sleep, rejuvenate yourself, and we will see tomorrow with some exciting events lined up for you. Thank you for joining us. Have a very, very good time ahead. Good night.